Hello, I'm Ronnie Eldridge. Welcome to Eldridge and Company. While there are many plans being proposed to make quality health care available for all people, I think the Community Healthcare Network in New York City already does that. Catherine Abate is the president of that organization, and fortunately, she's my guest today. So I want to know about this Community Health Network because it sounds fabulous to me.
Well, thank you. Well, it's a pleasure to be with you today. You've done such great work. I have to say that it's an honor
please,
to talk
Catherine,
with you.
Come on.
Yes, but Community Healthcare Network was once called Community Family Planning Council, and it was founded in 1981 when the Human Resources Administration came to its founder, Anna Dubois, and said, we have all these family planning clinics that are being run by different individuals. Would you consider forming a non-for-profit to take them over? So our roots are in family planning, and family planning is really women's health. It's not just about contraception. It is about health education. It's about nutrition. It's about primary care. So as the organization grew in size, it evolved into a primary care organization. And we're federally qualified health centers operating. What that means that it's designated by the federal government. And to become a federally qualified health center, you have to be located in a medically underserved community. Where they look at poverty rates, they look at healthcare needs, high incidence of chronic disease. And the mandate, if you are designated a federally qualified health center, is that you must provide care regardless of insurance, whether someone's insured or their ability to pay. And 51% of your board must be consumers. They must reflect the communities you serve and the populations you serve. And it's
and
so
do you get some money from this plan if you serve?
Yes, you can get money to cover some of the care for the uninsured. So does it cover it all? No, but it's obviously very, very helpful. So we have health centers in 4 of the 5 boroughs. We have a number of health centers in Brooklyn and 2 in Queens and 1 in the Bronx, several in Manhattan. And what's so wonderful about it is we're part of the community, and there are such enormous needs around health care in our communities.
And you don't serve women anymore. It's
everyone
everybody in the community.
It's everyone in the community.
So it starts with prenatal and it goes through pediatrics up to adolescent
adult medicine, and then geriatric. And still, most of the people we still serve are 50 and under. But, and we find that even now, family planning is the gateway to health care. Because if you can get a young woman to understand the importance of primary care, she becomes pregnant, she takes care of her child, her husband or partners come to the health center. She talks about the importance of primary care with her grandparents, her family. So it's very important to get the word out into the community. But the major issue is in New York City, there's 1.7 million people still uninsured, 2.5 million in New York State, and about 47 million people uninsured throughout the United States.
So in New York, though, we have, well, you've got Medicare, and then we had the Medicaid. What do we call that? The mandatory Medicaid?
Managed care.
Managed care.
Yes.
So why do we have people who are not insured?
Well, managed care describes how care is paid for and delivered. And the thesis around managed care was to encourage providers to provide holistic care, to not just provide a service, but health education. That doesn't insure more people. We still have, for the most part, many working people who do not get health insurance through their work, and that's why they're still uninsured.
So when they come in, you help them with their insurance and finances. Are they, what percentage of them are Medicaid
about 50,
eligible?
Of the patients we see, close to 50%.
I didn't mean to interrupt you because I wanted to hear about the program. But there's so many complicated things, and we hear so much, and I think we don't understand, at least I don't understand.
Well, why people are uninsured for a number of reasons. One, they're not working, and they're they don't qualify for Medicaid. Medicaid is very low level.
Right.
If you're an individual, you're talking about $10,000 income. A family of 4, it's about $26,000. But let's say you're above that, you're not going to qualify. Or if you're an illegal immigrant, you do not qualify for Medicaid. So there are individuals who are maybe working, the working poor, and or not, and it's usually the working poor. They don't get insurance through their job,
and they can't
afford it. They're struggling with how do they pay their next meal, paying their rent, taking care of their children. I see time and time again parents who will come in and make sure their children get health care, but they don't get the health care. They just don't, they don't even want to stay there because they're afraid eventually they can't pay for it.
Let's go back to your centers and your plan. The centers are like clinics?
Yes.
But they're not hospitals.
That's right. We're affiliated with New York Presbyterian Network and work with HHC hospitals.
So if a young woman comes in and you've done the family planning, and then the next step when she's pregnant, you then connect her to, or your doctor takes care of her at your center, and that doctor is connected to a hospital.
Or what we do is
refer them.
We refer them to hospitals, and we refer them to specialists, try to get them a timely appointment, call the specialist and make sure once the patient is seen, we get the reports back and we can continue the care. But that's very difficult. There are long delays for specialty care. And there are many specialists. They're going to see the private insurance first. Certainly aren't going to take the uninsured. And that's why we're I think we're 39th in the nation in terms of overusing emergency rooms. And what happens is families, instead of getting primary care, having a family doctor, making sure they get immunizations and all the care they need so they don't get diseases later, don't have that preventable care, that primary care, end up using and overusing the emergency rooms. And the emergency rooms become their primary care doctors. So what that means is higher and higher costs and more preventable diseases end up being very serious, not preventable, and becoming serious conditions for people.
Do emergency rooms have to provide service to whoever comes in, whether they're covered or not?
That's right.
But why do they then send such bills out? They try to collect,
well,
but they can't?
I believe they do a financial screening, and they figure out who can or cannot.
Right. And so the waiting lists aren't that great in your centers?
No, you can you can get an appointment. In fact, there are rules that say within a certain number of days, if you're a pregnant woman, you should get that appointment. No, we work with people. Anytime there's an emergency, there are walk-ins. If someone is sick, we'll have that patient triaged and perhaps seen immediately if that person's sick, or call 911, get them to a hospital.
And
so
there's
it's
no 24-hour?
No, it's just, it
so
depends.
If somebody gets sick at night? I don't mean that you're open, but there's somebody...
But they can, no, we have a call service where a patient can call at any time. A doctor will respond and help that patient.
So being in the community and being holistic, you must get involved in lots of different things.
Well, yes, there are. The things that I get involved in are the social service end, because working with social service agencies, working with the immigrant community.
And do you serve only documented people?
Oh, no.
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 Everybody?
Everyone. And right now, if you're undocumented child, you're covered by CHIP.
Right.
If you're undocumented pregnant woman, you're covered by PCAP. So we serve everyone. So many of the people in our community centers are immigrants. So it is being part of the community, so we have to know what the community's about in terms of social services. And so there are people that come out of jail that come to our centers. There are immigrants that feel that they've been isolated from the community. We're trying to reach out to hard-to-reach individuals. and do health education in our community, whether it's disease management, HIV care.
You have a very good website, and I was very impressed with the culturally sensitive delivery of services, which is so important. So, and in this holistic approach, what comes to my mind is this young woman that had a baby, and then the baby got sick and she took it to the hospital and they said it was nothing and everything, and then the baby died from malnutrition, and that was a case where they arrested her and she had a trial. That would never happen, right, to somebody in one of your centers, because she didn't know how to nurse the baby.
Let's hope so. And one of the things that all of us are struggling in the healthcare world is to change the model of care. It no longer should be the care where a doctor invites the patient in and the doctor does all the talking. Where it's not interactive, where the patient's not involved in their own care, where there's not self-management. And that's why the chronic care model works, because it increases the health literacy of the patient. And what I mean by that
what does chronic care mean?
That means diabetes.
Oh, I see.
These are
people with lifetime
obesity, diabetes, asthma, could be cardiovascular. And what's very important about it, the model is saying to the patient, how would you like me to show you this information? Do you like me to talk about in writing? Should I do a diagram? Let's talk about the country where you came from. There's increasing communication so that the information the patient gets when they go home is useful to them. And it's not about saying to all of us, not all of us, many of us are overweight, but there are children, 1 out of 4 children that suffer from obesity. So instead of saying to the parent, reduce her food, tell her to stop eating, well, that's no good. You have to go through, well, what is she eating now? Okay, she's eating ice cream 3 times a day. Why don't you think about reducing the ice cream to once a day? And then come back and let me know how she's doing. And let's see, substitute, maybe you try yogurt with one of those times. So you take bite-sized steps that are realistic goals for patients, but it's done through self-involvement by the patient.
So let's talk about the New York population. 1 in 4 children are obese. What about HIV/AIDS? What's happening with that?
There are a lot of people who would like to think that the epidemic is over,
right,
and it's not. And you and I were very involved in the 80s, where we saw, whether it was in the bars or Silence is Death, there was a huge public campaign about safe sex.
That was the ACT UP.
Right, safe sex and what to do around using dirty needles, if you had a partner, having a discussion to see if they had been infected. Those are all these things that communities, all kinds of communities were involved. Now there are a lot of young people who think, well, there are drugs, I can get AIDS, I'll be cured, people are living with HIV/AIDS. It's not a big deal anymore. So you're seeing a rise in the number of cases of HIV/AIDS with men having sex with other men. And 1 in 3 of the new cases of AIDS are also women. But by and large, it's really affecting the African American and Latino community. So we have a tremendous job to do to reach out to the community, to do health education. We do a tremendous amount of HIV counseling and testing, because that is our way of doing the health education, promoting safe sex, understanding what the risks involved. And so if people come in and they're negative, we can use that opportunity so they use good behavior in the future.
Yeah. And what other culturally sensitive things do you find?
It comes from, I mean, you know, there are issues of domestic violence that health centers have to be involved in, depression, doctors,
and you're covering
nurses.
mental health.
Yes. We're in Article 31 in our Brooklyn facilities, and we do psychosocial assessments.
What's an Article 31?
That is a license given by the state to provide mental health services.
Are you getting any veterans in here? Or are they abandoning?
I don't know if we have a huge number of veterans. Yeah. They may be going to the veteran hospitals or other.
So do you classify, are you a health maintenance organization?
No.
What's a health maintenance organization? Can you, I don't want you to spend a lot of time.
We're a provider. Our centers are made up of doctors and nurses, nutritionists, health educators.
So you're the health side.
We're the health. We provide the care directly to the community. And managed care, the health organizations, are those organizations, are insurance companies. They provide, cover the care. They pay for the care. And the difference between the old insurance model and the managed care model is that there's a greater emphasis on health outcomes, the delivery of care, looking at the totality of the treatment for that person. So they pay for the care, it's a capitated rate per member per month, whether they're seen or not seen. And the old fee-for-service paid for a particular service that was rendered. And so the reason to go into managed care, whether it works or doesn't, will be left to other people to figure that out. But it is to create a model, a more comprehensive model of care.
So do you work with a managed care organization? A lot of them.
Our doctors are credentialed with a number of managed care companies.
Right.
And so if they see a patient that is enrolled in that managed care insurance company, we're paid through that company. And they're supposed to look at performance, they're supposed to look at immunization rates, medication issues, health outcomes. And that's what it's all about. We're supposed to not just provide health care, but improve people's health.
Do you find that they say they won't pay for something that you do?
Sometimes, and then you have to go back.
Okay. Now, what's an HMO? Is that the same thing?
Yes. Yeah.
It's equivalent.
Yes.
So it seems to me you are providing health care to everybody.
Yes.
Now, why aren't you a model for a national program?
I think the federally qualified health centers are a model. Because what we concentrate on is not just the doctor seeing the patient. It's looking at the totality of that person's life. May need social services, may need nutrition, health education, counseling and testing, etc. But the health education is so key because it's what you do at home.
Right.
If you have asthma, what kind of mattress do you have? How are you making sure there's not mold and mildew and dust that aggravates a child's condition? So, and the fact that we don't turn people away.
Yes.
Which is very, very important.
And the fact that you're so much a part of a community, which is what I think is increasingly being realized, that those are the most successful programs.
Right. But there are federally qualified health centers throughout New York State and throughout the United States. And there are many in New York City. There are many in not just urban areas, rural areas throughout New York State. And altogether, the federally qualified health centers serve about 1 million people in New York State.
So, but it's so interesting because they could cover everybody.
Well, but you have private doctors out there.
Well, that's a choice.
Right, that's a choice.
Right.
You have health clinics that are operated by hospitals.
But you're giving everybody a choice.
Yes.
But you're there as a safety net.
We are a model. We're clearly a safety net.
So is that reflected in any of the plans?
Yes. The governor is now talking about putting more money in primary care and making sure the Medicaid reimbursement rate reflects that investment. I've always said, let the hospitals do what they do best and let the community do what they do best. And so if that happens, there won't be wasteful procedures, people ending up in hospitals, in emergency rooms, if early on in a young person's life, they get the care they need.
Right. And that connection that just stays with them.
Right.
Now, but is that reflected in any of the national proposals?
There is. Every candidate does talk about primary care. If you know anything about health care, they're saying we have to invest in health care, smoking cessation. If the things that you do and you through the programs in the schools, and health education programs and tell people about smoking. If it's done correctly in an early age, you're not going to have so many people in hospitals dying of cancer. It's a whole continuum of care.
When you said most of your people are under 50, is that because the people who are over 62 or whatever are Medicare covered?
They are Medicare covered and perhaps Medicare covered. And perhaps they've had a doctor of long standing and they go to an individual doctor. And it just be the population we've reached out to. A lot of who comes to us is through word of mouth. We serve one family, maybe 3 generations of that family. They tell people in their community. And there may be another federally qualified health center that sees more people over 50. It's just the population.
And if Medicare were expanded to everybody as a national program, it would be too expensive for the federal government because they're the full reimbursement, aren't they?
But if you look at, if everyone was insured, you would not only increase health outcomes, America would be healthier, but you also would lower costs.
And you'd have the leverage with it.
You'd have lower costs because you wouldn't need the number of hospital rooms, the emergency rooms. And so it's, I was Commissioner of Correction, remember that? And I used to talk about, why not talk about prevention and talking about quality education and putting mental health services in communities, because maybe someday you won't have to build as many prisons. But no one likes to invest in the front end because it's money that maybe doesn't pay off tomorrow, or today it pays off tomorrow. And they keep adding to tertiary care. And now more and more people are saying we can't afford it anymore. Counties are going bankrupt. And people are getting sicker, more uninsured. We're going to have to take a different look at all this and invest in communities, invest in primary care.
So are you trying to affect policy? Because let's talk a little bit about you. They're very lucky, actually, to have you because you have that wonderful combination. You've been an administrator. You've been a state senator, so you know the legislative process or what it isn't. And a commissioner's.
And a lawyer.
And a lawyer.
For Legal Aid Society for 13 years.
Is that right?
Yes.
So you've really seen it. How many people in your healthcare profession have that same perspective of how to make the change?
I think a lot of them do, particularly at the higher level. They understand that they have to engage in the federal government, state government, because it does affect, those policy affects reimbursement. It affects how our patients are treated. And one of the things, what I've seen in the federally qualified healthcare centers and healthcare in general, there's so many people so committed about putting patients first. They are there because they want to do right by the community and also by the patient. So I think inevitably, if you're a good administrator, you can't just be focused on what happens in your own exam rooms. You have to go outside in the community, see how the community is impacted by policy, and be a voice to help them. And to the extent possible, it's really our obligation to do that and get involved in policy.
So are there organizations that you do it together, or does everybody do it separately?
CUNY is the statewide organization that represents all it's Community Health Centers of New York State. I think I got that right.
Good.
And they represent, it's the trade organization representing all the community health centers.
And these, let's qualify this, these are not lobbyists for individual and personal enrichment.
No.
These are the lobbyists who educate the elected officials.
That's right, exactly. And in fact, they're a non-for-profit. They're there to help policy, give information about what happens to patients.
And then nationally, what happens?
Then there's NAC, which is an organization.
The National Association of Community Healthcare Providers, right?
Yes. And there are other non-for-profit organizations looking at healthcare. There's a huge debate between single-payer, a universal healthcare of choice.
Single-payer is
there aren't numbers of insurance company. There's one infrastructure that pays for it, delivers that care, and decides the reimbursement rate. There's still a debate around this single-payer system. You reduce the bureaucracy. you get care where it's needed, and then you poll people out there, and a lot of people say, I like my health insurance program. I like having choices. I like the competition. So you see many of the presidential candidates talking about universal health care, but also talking about
plans
choice.
for the two of it.
Right.
So with the smoking regulations, has that improved health?
I think so. Yes.
So then we can look forward to the campaigns for obesity and other things to also help to improve it for the future?
I hope so. Yes, because if you look in New York City, there's just such a high incidence, particularly in poor communities, of diabetes, obesity, asthma, cardiovascular disease. And then you see the correlation between poverty and lack of insurance and the fact that many of these individuals do not get preventative care. And then we need to, what are the schools doing?
Yeah.
You know, they're a very important place to reach out to parents and children.
Yeah, we're at the end of our discussion.
Oh, okay.
So let's just mention the website.
Okay. It's CHN, www.chnnyc.org.
Great.
And it stands for Community Healthcare Network.
Thank you very much, Catherine Abate. It's been a pleasure.
It's always a pleasure being with you. Thank you.
If there are any people you'd like to hear and topics you'd like us to explore, please let me know. You can write to me at CUNY TV, 365 Fifth Avenue, New York, New York, 10016, or you can go to the website at cuny.tv and click on Contact Us. I look forward to hearing from you.